Hey everyone, welcome back to my unboxing and unpacking and reviewing California state bills. I'm Sarah Davis. I'm a candidate for our state assembly here in California in the 78th district. I live in San Diego, and the district I'm running for runs up and down our coast. What the state assembly does affects all Californians. So I watch bills, both as a candidate and as a constituent and a Californian myself. These two that I'm gonna review and unbox today are absolutely near and dear to my heart. These are both from the nerdy policy perspective scope of practice bills. From the everyday person perspective, these are a matter of life and death. These are whether or not people have access to primary healthcare providers and reproductive healthcare providers when they need them. So these are a really big deal. California doesn't have enough primary care providers. So primary health care meaning your family doctors, your general doctors, family nurse practitioners, physician's assistants, everybody who's working in that first level of care that you would get in a doctor's office, in a clinic, in a healthcare center. And we are facing about a 4,000 provider shortage in our state. Coming up in the next 10 years or more. I mean, I think that that's a conservative estimate of the shortfall. I think we're missing more than 4,000. Those are really hard to make up. You can't just conjure primary care health providers out of thin air. So that's one thing right there. Specifically on the nurse midwife side, so as you know, I'm a licensed midwife. I care very much about birthing people and their options and ability to give birth with whoever they want to. So that on the nurse midwife side, we have a shortage of maternity care providers or childbirth care providers in our state as well. 9 of our counties don't have any care providers for pregnancy and birth at all. And in the coming years, our largest counties in Northern and Southern California are going to have critical shortages. Right now, we're short providers, and that's going to get worse and worse. So in all aspects of primary care, and particularly in maternity, maternal infant health care, we are short. So what are we going to do about it? These two bills are about bringing in more providers and allowing those providers to work to the full extent of their ability. So I'm gonna unpack AB 980. This one comes in very, very squishy, thick padding. Let's see what's going on in here. Seems a little overpackaged, but I usually feel that way about everything having to do with healthcare providers. Oh, we got another envelope. See what's going on here. AB 890 is currently in the Senate and is needing to be passed its policy committee in the Senate side before it can go back to the Assembly and then ultimately over to the governor. So AB 890, nice thick bill after we pulled it out of its multiple excessive packaging. So for me, that totally represents what's going on for nurse practitioners in our state already. They are working in an overly restricted, unmanageable, and confining practice environment. So compared to other states, like here, let's look at the facts here. Nurse practitioners in California are far more restricted. You don't usually expect that about California. Usually we're kind of ahead on like some of the evidence-based stuff out there. We're totally behind on this issue. So this bill would allow nurse practitioners to work independent of a physician in their practice environment. So that means they wouldn't have to have a physician sign off on their work, have a written agreement with a physician that says, yes, you can practice. This also means that they wouldn't be tied into a financial relationship with a physician, and it means that nurse practitioners would be able to keep going and keep working after, say, the physician that they work with retires or moves out of state or moves out of the town that they're working in. So that is really critical. So what is going on with this specific bill? It is introduced by Assemblymember Wood. It has quite a few co-authors in both the Assembly and the Senate. That's a good sign for a bill. So up here at the top, if it has a whole bunch of people listed that they signed on, that means that they are like extra supportive. They're not just gonna vote for this thing, they've been willing to put their name behind it. This is something that our state legislature has attempted to do a whole bunch of times. And perhaps surprisingly, perhaps not surprisingly, the people who oppose every time are the lobbyists and the lobby groups for the physicians themselves. And again, not surprisingly, once again, this time around, they are the ones in opposition as well. So details on this bill and the pieces that are really critical to me. On the one hand, yes, nurse practitioners would be able to practice independently. On the flip side, they would have to have this transition to practice period, which would be, how long is it exactly? This is not ideal. Transition to practice, meaning a period where the nurse practitioner has to work still under supervision of a physician, has been shown to really reduce access to care in other states. So this is not great. But if this is like the absolute best they could do in a compromise with our really strong medical lobby, and there was absolutely no way that the nurse practitioners could get this done any other way, I can understand why they agreed to a transition to practice period. It's really not great though. And I'm just trying to find exactly how long it ended up being in this particular bill. Minimum of 3 full-time equivalent years of practice or 4,600 hours. That's ridiculous. That's way too long. And again, I support the bill because we need to make this happen. But that's ridiculous. And here's the reason why it's ridiculous. If we're trying to bring in providers to meet the need in places where we don't have providers already, putting in a transition to practice requirement just means we don't fill those needs, because we're keeping these new nurse practitioners in a setting that already has providers, because it already has the provider, the physician, who's going to supervise this person. The most amazing and beautiful part of practice like nurse practitioner or nurse midwifery practice is you can build up that workforce in the places and in the communities where you need them most. So if we desperately need providers in the Central Valley, but we say, oh, you have to spend 3 years in a major urban center after you've already gone to nurse practitioner school, that means that somebody's going to establish themselves for 3 years before they move out and start their independent practice in the Central Valley where we need them. Especially if it was someone from there. Maybe it's someone who has young children. They're going to establish somewhere else, and there's kids to school somewhere else, and then have to move again. It's an unreasonable burden, but we're going to be okay with it if this is what absolutely has to happen in this bill. So that's my take on AB 890. Could be better, but we're going to take what we can get. And moving on to SB 1237. SB 1237, also coming in a pretty big box. Ooh, at least it's pretty inside. Everybody loves babies. Everybody wants to talk about making sure that we have access until it comes down to actually doing it, and then it becomes really, really hard. It's very popular right now, even in mainstream, newspapers and on mainstream television, mainstream news. to talk about these beautiful baby topics and some of the really unbeautiful parts of it, like how incredibly high our maternal and infant mortality rates are compared to other developed countries. Got the bill all wrapped up. The reason we have such high maternal and infant mortality rates in this country is several-fold. One, and the major driver on the statistics, is the high rates of death for moms and babies who are of Black and African descent. And that is due to racism, specifically, clearly, and in the evidence. It is due to provider implicit bias or explicit bias, but we'll just go with implicit bias for sake of conversation, that Black birthing people and their newborn infants are treated differently due to racism. Their concerns are not taken seriously. This isn't just about having access in a socioeconomic sense, although that's a piece of it. It still means that medical providers think that Black people's concerns, when they're voiced, aren't as valid and serious. This is where you see someone like Serena Williams, who has all of the socioeconomic privilege, but still had a catastrophic birth, and was treated very badly and had injury that shouldn't have happened to her. That's one reason. The other reason that we have bad birth outcomes in this country is our for-profit medical system, the fact that we are driven into people have to have their babies, by and large, most people, in a system that's driven by profit. The system that's driven by profit means that we are always trying to fill beds and empty beds and move people really quickly. It means that providers and hospitals are trying to do a lot of cases, and they're trying to do the cases with the people whose insurance pay the more. And so it's not in any way designed around what actually works best to help a birthing body birth a baby. The antidote to that is midwifery care. And nurse midwifery care has a 100-some-year tradition, about 100-year tradition in the United States. Is pretty well established in every state. It's legal in every state in this country. It's been legal for decades and regulated in California for decades. But nurse midwives in California are still under an unreasonable, restrictive, and petty restriction that they have to be supervised by physicians as well, similar to the nurse practitioners. Most states don't require this. California is one of 5. We're not in good company on which ones those are either. It doesn't improve outcomes to have physicians supervising. It doesn't improve access. It doesn't improve anything, but it does impede access really severely. So we have far fewer midwives and independent midwife practices in this state than we should have, based on our population, than we would if we had a better practice environment for nurse midwives to practice in. Some of the states with good practice environments, like Washington State or New Mexico, have far higher rates of use of midwives, far higher rates of satisfaction of the patients, the birthing people themselves being happy with their care, and far lower rates of cesarean birth. And cesarean is an incredible, important, life-saving intervention, but like all major life-saving interventions, should not just be used when not necessary. And it is definitely overused in that for-profit system that's trying to constantly move people through quickly, and without regard to their long-term public health outcomes. So what does this bill do? This is also like the umpteenth attempt to remove this outdated physician supervision restriction for nurse midwives. They have had a bill to this effect almost every year for the last 5 years or so. And They have not been successful, again, due to the physician lobby. Doesn't mean that individual physicians don't support both autonomous practice for nurse midwives and for nurse practitioners. They do. But the lobby that is protecting the institution of the practice of medicine does not want these folks to practice independently. And they use a whole lot of excuses for why they think that's true. So this particular bill would strike that physician supervision requirement. And from my perspective, that should be the end of the story. Just like the nurse practitioners, that should be the end of the story. You're not required to be supervised. Carry on. Do your work as you're trained to do. However, in both cases, there had to be compromises made because that's how politics works. So the nurse midwife bill here ends up outlining a set of circumstances where there does have to be a physician relationship and some practice protocols that are agreed upon and signed with a physician. It's not my favorite because, again, the evidence supports having nurse midwives have an autonomous scope of practice and do the work to the extent of their training, just like doctors and dentists do their work to the extent of their training. That's it. They don't have all these nitpicky details. But since we have it, I will say that I support this bill and I believe that this is better than the situation that nurse midwifery practice is in today. Because today, they have to be supervised for everything. And tomorrow, whenever, this bill passes and is enacted, next year, assuming it passes, they will not have to be supervised for everything. They will only have to be supervised for some things. So opposition to this bill comes from a couple of different places. One, like I mentioned, medical lobby. Another one is a set of midwives and midwifery consumers who are so opposed to that list of conditions where nurse midwives would have to work in consultation or with standardized procedures with a physician or practice protocols that they believe that the whole bill should be thrown out. On the medical side, they don't have any evidence or philosophical backing for their opposition, and I just don't care. I care a lot on the midwife and midwife consumer's perspective. This is incredibly important. If this bill took the current practice of nurse midwifery backwards on those issues, I would oppose it as well. I am willing to see this go forward, even though it does outline those pieces, because it will help us build midwifery practice in the state. We will be able to get more nurse midwifery schools in CSUs, which we've actually had a massive decline over the last couple of years. A massive decline, down 50%. It's pretty massive. It's from 2 to 1, but it's too much. And we need to be building all of these practices that can support this. It's not great, it's not perfect, it's not ideal, but we need to build the power and we need to build the workforce. So those are my 2 reviews of these 2 bills. Go to the state website, find the bills, go to the analyses. It'll have a little tabs at the top, so like text, analysis, votes, status, You can read the analysis as these bills went through the different committees and were amended in different ways. You can see what the policy analysts have to say about them. You can see their arguments in opposition and arguments in support. And it's really helpful for understanding where this is going. The bottom line is we have to have autonomous practice for these practitioners. We are down providers anyway. We're extra down providers because of COVID. Then we're going to be extra down providers with the coming recession, with more and more people needing their primary care right where they are. And there's people like me who want to expand access, who want us to have universal healthcare for all Californians. If we're going to have universal healthcare, we need a whole lot more providers. We have to have bills like this. They should be stronger, and we can get there. But for now, we have to let these go forward, do their thing, and come back when we need to make their position even stronger and their practice environment even better, so we can have even more of them. We should have no shortage of primary care providers. We've got so many people who want to work in healthcare, who want to work in culturally congruent healthcare, meaning from the marginalized community that they live in, they want to be a provider. That's what we need. That's what changes outcomes. That's what keeps people safe. That's what keeps all of us safe. That's what we got to do. So this is SB 1237 and AB 890. Both are active in policy committees right now. So look them up, call your assembly people and your senators. And again, I'm Sarah Davis, running for state assembly. I think we need to have reviews of bills for people all the time. We've got to have this kind of transparency. We can't let this stuff happen behind closed doors. When it happens behind closed doors, all kinds of ridiculous stuff happens. But most importantly, big corporate power always wins behind closed doors. So I will see you all soon for our next review of our next bill.